a sister or friend. Although the number of cases reported from Western Europe is declining, more cases are being reported every day from Eastern Europe, Africa, Southeast Asia, the Eastern Mediterranean, and the Americas. However, even within regions and within countries, we see divergent trends. Every country and every region needs a tailored approach. But the impact of the pandemic goes far beyond the numbers of cases and deaths. Around the world, the pandemic has caused severe disruption to essential health services, including to community-based health care. Also, professional health workers like doctors and nurses play crucial roles. In many countries, trained members of the community play a vital role in delivering essential health services like vaccination, prenatal screening, and the detection, prevention, and management of many diseases. Today, WHO, UNICEF, and the International Federation of the Red Cross have published guidance for countries on how to maintain community-based healthcare in the context of COVID-19. It includes practical recommendations for countries on sustaining essential services at the community level, leveraging community health workers for the response to COVID-19 while keeping them safe, and advice for how to adapt services for specific diseases and age groups. For example, it suggests using telemedicine wherever possible and leaving insecticide-treated nets for malaria at the door of households instead of asking people to collect them from a central location. It's also vital that countries pay careful attention to the most vulnerable members of their societies. Crisis can exacerbate existing inequalities, which is demonstrated in higher rates of hospitalization and death among certain populations in many countries. We must address this now and in the long term by prioritizing diagnosis and care for those who are most at risk. This is not only the right thing to do, it is the smart thing to do. We cannot end the pandemic until we address the inequalities that are fueling it. Today's guidance complements the United Nations Framework for the Socio-Economic Response to COVID-19, published last week. The framework lays out a recovery roadmap for countries to protect lives and livelihoods. I repeat, lives and livelihoods, and get businesses and economies up and running again as soon as possible. Importantly, the framework takes a health-first approach, recognizing that strong and resilient health systems must be the foundation of recovery in all countries. As more and more countries consider how to ease the so-called lockdown restrictions, I want to reiterate the 6 criteria that WHO recommends countries consider. First, that surveillance is strong, cases are declining, and transmission is controlled. Second, that health system capacities are in place to detect, isolate, test, and treat every case and trace every contact. Third, that outbreak risks are minimized in special settings like health facilities and nursing homes. Fourth, that preventive measures are in place in workplaces, the schools, and other places where it's essential for people to go. And fifth, that importation risks can be managed. And sixth, that communities are fully educated, engaged, and empowered to adjust to the new norm. The risk of returning to lockdown remains very real if countries do not manage the transition extremely carefully and in a phased approach. The pandemic has highlighted the importance of strong national and subnational health systems at the foundation of global health security and universal health coverage. Strong and resilient health systems are the best defense not only against outbreaks and pandemics, but also against the multiple health threats that people around the world face every day. And yet, on current trends, more than 5 billion people will lack access to essential health services by 2030, including the ability to see a health worker, access to essential medicines, and running water in hospitals. Gaps like this don't just undermine the health of individuals, families, and communities. They also put global security and economic development at risk. The world spends around US 7.5 trillion on health each year, almost 10% of global GDP. But the best investments are in promoting health and preventing disease at the primary healthcare level, which will save lives and save money. Prevention is not only better than cure, it's cheaper and the smartest thing to do. The COVID-19 pandemic will eventually recede, but there can be no going back to business as usual. We cannot continue to rush to fund panic, but let preparedness go by the wayside. As we work on responding to this pandemic, we must also work harder to prepare for the next one. Now is an opportunity to lay the foundations for resilient health systems around the world, which has been ignored for long. That includes systems to prepare, prevent, and respond to emerging pathogens. If we learn anything from COVID-19, it must be that investing in health now will save lives later. History will judge all of us, not only on whether we got through this pandemic, but also on the lessons we learned and the actions we took once it was over. And then before I end, I will just repeat something that I said many times. The antidote for this pandemic is national unity and global solidarity. Together, we will defeat COVID-19. I thank you.
Thank you very much, Dr. Tedros, for these opening remarks, and we do indeed welcome Hindi speakers to our press conference. Again, we are working with Zoom that has particular technical modalities. So, for example, Arabic speakers need to go under Korean language if they want to choose Arabic language, while for Hindi speakers they have to go to Japanese language. So hopefully this thing will get better as we move forward. Also, for the time being, Hindi speakers can only listen, and then questions will have to be said in English, but we also work on that. In any case, it's very good that we can reach to more and more people. So before we go to question, I would just like to remind everyone that we need to be very concise and one question per person. So I'll just check with my colleague Chris who we would have first in line, and let's go with Ankit from India today. Ankit, you have the floor.
Good evening. My name is Ankit Kumar. I represent India today. My question is on contact tracing applications. More and more countries are rolling out their own versions of these applications. Is there any data or study, or can you tell from your own experience if these applications are helpful in controlling the pandemic threat? In your opinion, should these apps be mandatory for those going out on work during the lockdowns, as the case is in India? Thank you.
Thank you, Ankit. This was about contact tracing applications.
So I could start, and perhaps Mike or DG would like to supplement. So thank you for the question. Contact tracing remains one of the fundamental tasks that need to be done to help control transmission of COVID-19. And what we mean by contact tracing is when you identify a case through your surveillance systems, that you identify all of the contacts, all of the people who are in contact with that known case, and then you follow them over 14 days. Your question was specifically about apps, and apps can supplement the work that needs to be done by people. The work that needs to be done by individuals who can go out and actually interview cases and find out who did they come in contact with just before they became symptomatic and while they were symptomatic before they were isolated. And that needs to be done by a group of individuals, and many of them are trained in epidemiology, but you don't have to be trained in epidemiology. We've seen many countries use different workforces, volunteers who are trained, school teachers we've heard of students who can help with this contact tracing. And what's important about an individual, the people that do this, is that you need to find cases through personal interaction and through interviews, all done physically distanced, of course. The apps can help, but they don't replace people who need to do that contact tracing. And what we're seeing is a lot of apps and a lot of applications that can help find people who may have been around somebody if they're using smartphones within a certain distance, and that can help narrow down the number of contacts, but it doesn't replace the individuals who actually have to go out and do the contact tracing.
Yes, just in supplement, there are different applications out there, and many countries have developed them, many consortia have developed them, and in academia and the private sector. There are apps out there that help people learn about the disease, and there are some very useful apps out there that provide better information about the disease and good information, and that also, in some cases, help people check their symptoms. In other words, allow people to get information regarding the symptoms of the disease, check their symptoms, and see if they should take further action. There are also mobility tracking applications where people doing modelling, and you've seen that with IHME in the US and other modelling institutions, where in the background they're checking the overall mobility of the population, which helps drive the modelling and prediction of disease, because clearly if people are more mobile and mixing more, you can use that to make your model more accurate about the likely future incidence of the disease. And then there are the apps that can help with contact tracing, and that's the many countries, the UK I think have just finished testing their app. What that app allows public health authorities to do is to, number one, potentially, in Korea have a similar application, is help with the tracing process. Once someone is sick, what would normally happen is they'd be tested and isolated. As part of that process, the public health authorities will ask them about who they've been in close contact with in the previous days. And that is a difficult process, remembering exactly who you spent a certain amount of time with in certain settings to see who the high-risk contacts might have been. A way to supplement that is to have an ability to use mobile phone technology that can actually remember, in a sense, for the person, because your mobile phone can remember who you were close to in the last number of days, and it can actually calculate how long you've been close to that person. So what it does is it provides an aid to memory for that process, and that can be very good. It can also be used to notify those contacts that they have been in contact with a confirmed case, which allows them to take appropriate action. For all of this to obviously work, it involves the Bluetooth function on people's mobile phones to be activated and people to accept that they wish to use this application. And I think that's where we have an opt-in process, many countries have an opt-in process for that. Each country is using a slightly different application with slightly different opt-in or opt-out processes. And obviously countries have to take very good care of the fact that tracking people's location needs to be done for the sole purpose of COVID-19 response, and that is something that is being discussed actively in each country. From our perspective in WHO, we are working with many of these developers around the world and looking at these applications and then trying to establish applications or bots that we can offer to countries who they can adapt for their own use should they wish to. A good example of that is the GoData application, which is a contact tracing system that allows countries to maintain a very sophisticated database of contacts, cases, lab results, and allows public health authorities to construct transmission chains and manage the whole process of contact tracing. We have made that application available to all countries, and many countries are now using that as a way of managing all of the data around cases. That does not involve individuals' mobile phones being tracked in any way. That's just purely to aid the process of contact tracing and the process of integrating all of the data. And one of the weaknesses in this whole response, or one of the challenges, has been how do you integrate data from the hospital, data from the public health system, data from the lab. And you've seen the frustrations when people say, we don't have the data, or where is the data? Very often the problem is that different parts of the health system are generating data for different purposes, and that data doesn't come together in a way that helps drive the response, and it takes time for that to happen. So applications that are assisting with that are extremely useful. So I would just like to clarify, it isn't one app, it isn't one way of doing things. Each and every one of these apps to be looked at by national authorities and to see how the app can help them do a better public health job of testing, tracing, tracking.
Thank you very much, Dr.
Merci beaucoup à tous les deux. La question suivante.
Следующий вопрос. Anatolia News, турецкое агентство. Байрам, слышите ли вы нас? Байрам, пожалуйста, включите свой микрофон. А сейчас слышно? Пожалуйста. Спасибо за возможность задать сегодня вопрос. Наша турецкая футбольная федерация объявила о том, что примет у себя финал Лиги чемпионов. И сейчас у нас приостановлены соревнования. И были проведены некоторые матчи в мае без зрителей. Мы знаем, что у вас есть контакты с УЕФА и ФИФА. Какие рекомендации вы можете сформулировать футболистам по возобновлению матчей в Европе? У нас есть конкретное руководство по массовым мероприятиям в отношении всех спортивных мероприятий и как нужно ориентироваться на риски. То, как прислушиваться к этому, это суверенное право федераций и правительства, которые проводят у себя подобные мероприятия. Вы привели, конечно, пример конкретный, связанный с футболом. Футбол, да, такие соревнования бывают и со зрителями. И...
Pour assurer la sécurité des différentes personnes. Donc la question est de savoir quels sont les risques, comment est-ce que ces risques sont gérés, et ensuite quel est le processus qui nous permettra d'y parvenir. Et donc je crois qu'il faudrait avoir des informations spécifiques pour la Turquie, pour l'Allemagne, et pour voir quelles sont les mesures de limitation des risques qui ont été adoptées. Et Je pense que si les gouvernements, les fédérations de ces pays nous posent la question, eh bien nous sommes tout à fait prêts à leur donner à la fois nos conseils et nos avis. Merci.
Thank you very much, Dr. Ren.
Большое спасибо. Насколько я понимаю, у нас возникли проблемы с стримингом на некоторых языках. Надеюсь, что мы будем в состоянии решить нашу проблему. Давайте перейдем к следующему вопросу.
Be fixed soon. So why don't we try with CNN contributor Michael Bosyurkiv. Michael, can you hear us?
I can hear you. Can you hear me?
Yes, please ask your question, and we are trying to sort out the issue with the languages.
It's all right now, actually. The problem's been corrected. Thank you.
Thank you for taking my question, and greetings from Vancouver Island. Dr. Tedros, Prime Minister Trudeau was one of the last world leaders to indicate that he'd like to examine the timeline for the declaration of the global public health emergency. And I wanted to ask you, in 2015, an independent panel of experts that included members of the Harvard Global Health Institute and London School of Hygiene and Tropical Medicine, well, they recommended that WHO consider handing over its declaration responsibility and that there be establishment of a new global health committee within the UN Security Council. I'm wondering, given the criticism of the White House and concerns of other world leaders, would WHO consider a reform to that extent, at least to tamp down some of the concerns and criticisms coming from world leaders? Thank you.
Yeah, thank you. On assessments, I know WHO has a culture of assessing issues, and it has a process called after action review. And WHO actually wants any assessment more than anyone. And we will do the assessment when the time comes, and what we call the after action review. So we will see what happened based on the timeline when we do the assessment. But now I call upon the world to focus on fighting the fire, because while fire is raging, I think our focus should not be divided, and we should really focus on fighting the fire and saving lives. I thank you.
Thank you very much, Dr. Tedros. So next question goes to Penry People's Daily. Please unmute yourself if we can. Well, do we have someone from Penry People's Daily? Okay, so then we will go to the next one. Let's go to Jamil Chade, our friend based here in Geneva, representing a number of Brazilian press. Jamil, please.
Tarek, thank you very much. This is Jamil Chade. My question in Portuguese. Sr. Tedros.
Dr. Tedros, my question is about the specific situation of the city of Manaus in Amazonia, which has a very high number of cases, and the prefect of the city is calling for international aid. And there's a great deal of concern on this issue in Amazon. And is there any specific aid from the WHO for Manaus and the Amazon region?
Please, Chief.
Yeah, as you know, we're working with the government of Brazil, so we will continue to work with them and address, or give any support they need. Thank you.
And if I may supplement that, on request of the government of Brazil, we have very often in the past worked at state level, and we've done that with yellow fever in the past on many occasions. So obviously, and we have a strong WHO country office there, or a PAHO country office, and we stand willing to provide direct technical support to any state through the process of a government request to do so.
If I could just add, it's not specific to Brazil, but just to say that in this new normal that we're in right now, where we're not able to travel, we're not able to get to all of the places that we would like to get to, we're finding new ways in which we can try to provide support to countries. And in some countries, we're doing these virtual missions where we have a set agenda and meetings where we're having these missions over Zoom, over Skype, over whatever platform that we have. But just to add that even if we physically can't get to a location because of the pandemic, we're finding different ways to provide support where that support is needed and as that support is asked.
Thank you very much. Next question is for Wall Street Journal. We have Lucas on the phone. Lucas, please unmute yourself.
Hello, can you hear me?
Yes, it's okay.
Okay. I think my question probably goes to Dr. Tedros. This relates to the upcoming World Health Assembly and whether Taiwan will be invited to attend. Would you encourage the member states, particularly China, to allow Taiwan to attend as an observer this year? And conversely, I understand that you have the authority to invite them yourself. Would you do that if China continues to resist their participation? Thank you.
Thank you very much, Lucas. And I apologize that I did not introduce our guest, our fourth speaker here. It's Mr. Derek Walton, who is a legal counsel of WHO. He is here with us, and I think he would like to take this question.
Thank you very much. And yes, of course, we have the World Health Assembly coming up on the 18th and 19th of May. This year it will be held virtually, and it will be a de minimis session, which means it will focus principally on the COVID-19 pandemic. The involvement, if any, of observers from Taiwan, China in that assembly is a question for the 194 members of WHO, the member governments. It's their decision. And indeed, a proposal has already been made, as it has been in recent years, for this matter to be considered by the Health Assembly itself. And that is a question which is properly for the member states. But whether or not Taiwanese observers participate in the Health Assembly, there are well-established arrangements for health experts from Taiwan, China, to work with WHO on technical health matters. And I think we've already explained in some detail at previous briefings how that's worked. That last year, for example, Taiwanese experts were included at 8 expert meetings, and that there were 6 other informal technical meetings. And this year, there have been contacts in response to COVID-19 involving Taiwanese experts in key groups and networks. I think we've given details of that on previous occasions. But for this year, as I say, the question is for the Health Assembly. It's for the member states rather than the Secretariat to decide that question. Thank you.
Thank you very much, Mr. Walton, for this explanation. Next question is for Savio Rodriguez from Goa Chronicle. Savio?
Hi, can you hear me?
Yes.
Okay. My question goes out to Dr. Tedros. On January 14th, WHO stated preliminary investigations conducted by the Chinese authorities have found no clear evidence of human-to-human transmission of the novel coronavirus identified in Wuhan, China. As an independent global health organization, why did WHO have to rely on China's preliminary investigations into the human-to-human transmission possibility of the coronavirus and not conduct one of its own investigations, is my question.
Thank you.
So I can start, and perhaps others would like to supplement. So the 14th statement that you're referring to is a tweet in which there was the reporting of what had been reported to us from Chinese authorities. I think what is critical and what is important is how WHO acted from the moment we heard about this cluster of atypical pneumonia from Chinese colleagues in Wuhan. From the beginning, I'm the MERS specialist, the focal point at the organization. Mike led the SARS response. And so from the start, whenever you hear of a cluster of an atypical pneumonia, you think respiratory and you think human-to-human transmission. It's not if, it's just what is the extent of human-to-human transmission that may be happening. Within hours of that notification that was picked up through our EIOS system, we activated our emergency systems at the 3 level of the organization, which means our headquarters, our regional office, and our country office in China, where we were having discussions about what we knew, what questions needed to be asked. We immediately posed questions to our colleagues in China to ask for more information, as we do with all clusters or all alerts or all signals that we pick up through the electronic monitoring systems. From the beginning, we assumed that there would be human-to-human transmission, and in our first reporting to our member states and contact points on the 5th of January, it's in our EIS, which is Event Information System. We included detailed information about the cluster itself and also about protecting against acute respiratory infections. We also published on that day our first disease outbreak news. From there, we worked with our international partners to develop guidance, which is around how do you find cases, how do you protect healthcare workers, how do you treat patients, and all of those guidance materials were guidance materials that we adapted from our MERS guidance materials, which included information about how to protect for human-to-human transmission because these viruses are transmitted by respiratory droplets in contact. So our first guidance that was issued was on the 10th of January, which included information about how to protect against human-to-human transmission. So that's important. I did a press conference on the 14th where I did this with Tarek, I described what we knew, and at the time there were 41 confirmed cases. The novel coronavirus had been identified, PCR assays were available in China, and they confirmed that 41 out of the initial more than 100 suspect patients actually had this now we call COVID-19. But at the time we were calling it a novel coronavirus. And so in those 41 cases, described that there may be human-to-human transmission, mainly among close contacts. It's very important that you understand that we receive information from our member states, but we also go back and ask lots of questions. We always do this. It's not unique to this particular situation or unique to China. And we base our actions on what we know and what our experience is with other similar pathogens, other similar situations. From the beginning, we expected that there could be human-to-human transmission. It was just a matter of how much was actually occurring, where was it occurring. And so initially we thought it would be amongst close contacts through respiratory droplets, and that is still the case today.
Thank you very much.
Just one thing to supplement to in terms of maybe explaining to people the incident command system at WHO. We operate under a very well-documented emergency response framework, which is an organization-wide framework for managing emergencies. It is constantly under review. And in the process of epidemic or emergency intelligence gathering, we can get up to 3,000 signals a week sometimes that require follow-up. And what we're constantly doing is sifting through the various epidemic signals. We use our own expert networks to do that, seeking information from countries. The systems have AI components for looking for unusual events and picking them out of the background noise. For many outbreaks that occur, we would generally wait for some level of confirmation of the disease before triggering our incident management system for that specific event. We follow every event, but for certain events we trigger the IMS. The IMS is a special mechanism that creates a special and dedicated multidisciplinary team across the 3 levels of the organisation and ensures that that event gets a dedicated response for the amount of time it needs to bring the event to an end and to support our member states in that response. That incident management system was established for this event without a diagnosis of the disease, without the virus being known, on the 1st of January. And that IMS has remained in place every single day and has operated as one entity across the 3 levels of the organisation since that day.
So just 1 minute. I think it has been covered properly, but wanted to clarify one aspect. The rule we have in WHO and other UN agencies is when a member state reports, we post the member state report as is. So what we did on January 14 in the Twitter is we posted China's report as is. That doesn't mean that we agree or we disagree. We're just reporting what came. Sir, where are you from? The person who asked the question? From India. So if India reports, we post India's report as is. If my own country, Ethiopia, reports, we post the report that came from Ethiopia as is. And we treat the same way all 194 member states. But when we post their reports in our Twitter or website or wherever, we just put it as is and we don't change anything. But at the same time, if we have some differences with what is reported, as what Dr. Maria Van Kerkhove said, the same day or before even January 14, we can say it. And before January 13, Dr. Maria Van Kerkhove and other colleagues were saying there is a likelihood of human-to-human transmission. But not only that, even on January 14th, Dr. Maria Van Kerkhove and other colleagues were briefing journalists, and they said there is a likelihood of human-to-human transmission. And our guidance reflected all that. And then when China officially reported that it discovered human-to-human transmission, I don't remember the date, was it January 22? On January 22, we just reported again exactly as we received it from China. So that's a normal procedure. And we do it for any country. But that doesn't mean that we accept or not. And we express our own opinion. And the 14th January press conference was carried by many of the major media, including the Reuters, expressing the likelihood of human-to-human transmission. But the most important thing is our guidances before, during 14 January, and after actually included the likelihood of human-to-human transmission that helped countries to prepare. So we want you to have the full picture. And thank you for asking that question. Namaste. It's a very important one which is going around, but this is the whole truth. Thank you.
Yes, and just to supplement again, the DG, again to clarify that WHO has no special powers of investigation or deployment. Every time, and there are thousands of these events every year all around the world, where we're picking up signals, we seek to verify the existence of an epidemic with the country, we seek further information. But we always, on each and every occasion, offer the country assistance with investigation, diagnosis and respond immediately to requests from our member states to do that. And in this case, in addition to our 150 country offices, I think we've launched in excess of 80 surge team missions to support our member states already in this response. So we're